we talk about asthma, we think about chest tightness. What else? What is it?
Inflammation.
There is inflammation, right? The inflammation is what's causing the chest tightness. So what else? What else do we know about asthma?
Wheezing.
There is wheezing involved in asthma, right? So today's class, we're going to discover the pathophysiology, etiology, clinical manifestations of asthma, identify the risk factors, prevention methods. We're going to summarize the diagnostics. We're going to identify problems, and we're going to look at the planned evidence care for individuals. And after that, we'll evaluate expected outcomes, right? So how does asthma work? So in general, when we think about asthma, it's what you guys mentioned. It's the inflammation. But the thought is, why is there inflammation? Why is the body reacting this way? So it's a sensitivity, right? So the body noticed something, whether the person is either allergic to something or the body's reaction towards something that it doesn't like, right? So exercise, the person's not allergic to exercise, but the body builds this sensitivity or not sensitivity, but a reaction towards how, when a person is exercising. But if a person, let's say, is allergic to mites or dust or some kind of chemical substance, then the body does the same kind of reaction. And what happens is the immune system realizes it. When you think about your immune system, what it does is it notices there's a problem and it says, I need to go help. It brings white blood cells, platelets, red blood cells to the area, right? And it helps to relieve by fighting, destroying, cleaning, getting rid of whatever the trigger or the problem is. But in asthma, unfortunately, the problem is not something that's bacteria that it can fight and kill and destroy and get rid of. It's a sensitivity. It's a reaction. It's pollen, right? It can't really destroy it. So then it just continues to proliferate. It just gets worse and worse and worse until you give the person the medication that relieves it, right? It can't release or relieve itself because it doesn't know how to stop itself because it's not completing what it needs to complete, right? So what is it? It is an inflammation, and it's an inflammation where? Of the lungs. And how do we characterize it, right? We mentioned the wheezing, right? There's breathlessness, there's the chest tightness, and there's the coughing. And as you can see from this picture here, this is the picture of the bronchioles when they're normal, right? The area is open, patent. There's no swelling. There's no mucus that's too much for the body to handle. But then when we look at the asthma patient, we see spasms. We see the tightness around the bronchioles, right? We see the swelling that's being caused, and we also see an overproduction of mucus. We kind of talked about this before when we mentioned how when the body reacts to something that it doesn't like, the differentiation, when we talked about that, right? It does something in order to adapt, to accommodate, so that it can bring some kind of relief or it can help the person in one way or the other. Now, does that necessarily help? It tries, but does it cause some other kind of consequence, some other kind of discomfort? Sure, right? And it's up to us to try to mitigate that, to help it so the person is not harmed in a irreparable way, right? So asthma is a chronic inflammation. That's key to note. It's chronic. The other thing too is once a person has asthma, they always have asthma. Now, can it exacerbate and it comes and it goes? Sure. Does a person get back to the state that they were before the exacerbation? Sure. But it doesn't ever go away, right? We have kids or younger people who had asthma, and then when they're older, they're like, oh, I don't have asthma anymore. No, you still have asthma, right? But it doesn't manifest. You don't have exacerbations, right? So it is chronic. We have the mucosal edema, which we see in the picture. We have the mucus productions, right? And all of this causes the chest tightness, the iconic wheezing that we hear, and the dyspnea, okay? And so the most important thing that we have to remember, it is irreversible. It is not curable, right? It's reversible, but it's not curable. Reversible as in we can bring it back to the state that the person was before they had the attack, before they ended up in the hospital, right? But it's not something that we can just get rid of, okay? And we'll see the difference between asthma and COPD, which isn't reversible, right? Once a person gets to a certain stage in COPD, they stay there. And then if they exacerbate again and they get to another stage, they stay there. But asthma is not like that. Asthma, we can bring it back to a state where the person feels just as they were in the past and how they could function in a way that is good for them, right? So what are some of the things that caused it? Mast cells, neutrophils, eosinophils, right? These are our white blood cells that are coming to the rescue, that are causing this inflammation with asthma, right? When you look at patho, you'll see more in detail how the mast cells is part of the immune system and how they cause this concentration of blood vessels to get to the area that's going to cause the swelling. So one of our biggest problems then, right, if we have all this swelling, right, is that inflammation. When we talk about, which medications that we're going to give, we got to think about, okay, right, we mentioned, oh, we're going to give something that it got to open up, because if it stays closed this way, no air is going through, and we know how important air is, right? So we got to open it up, but we also have to do something to the inflammation to keep it open. But our first priority we're going to see is opening it up. But definitely that inflammation is important to take note of. Okay, so let's talk about some of the risk factors. And the risk factors are the same kind of risk factors we've seen for all of our respiratory issues we've covered, right? We talk about age. So when children, when people are younger, right, asthma hits them much more easily at that younger age because underdeveloped lungs, right? And a lot of times we have asthma in children that live with, families that smoke, or in neighborhoods where there's a lot of pollution, right? So the environment matters, but the age does take a great effect, okay? Then we have the family history. Also is a problem there too, right? We have smoking exposure, environmental exposure we just mentioned, and GERD also is a problem with the reflux that's happening that's already causing some trauma and problems to that area, so then person is more prone to having the asthma. So here are the triggers, right? When we talk about triggers, what do you think we mean when we say triggers? Triggers are things that initiate it, right? That causes it to happen. So if it causes it to happen, if we remove the trigger, will we have an exacerbation? No, right? So the person will have asthma, okay? They're diagnosed with asthma, but if they never get exposed to their trigger, then they won't have an exacerbation. They won't feel, that chest tightness and that, or pain, or the coughing, shortness of breath. They won't get that. So our goal, right, would be to teach our patients about their triggers, right? Do you know what your triggers are? So what are the triggers? The triggers, they can be extrinsic, right, which is the hypersensitivity, it's atopic, or it could be intrinsic, which is non-atopic, and it has nothing to do with the immune system, right? And so some of the extrinsic ones connected to allergy, they say 50% of people, right, it's this antigen that's connected to our cells that says, okay, this antigen is Nicolette, right? It's connected to my protein that says Nicolette. But anything else that's foreign, how does my body identify as foreign? It doesn't have Nicolette's signature on it. So the body says, oh, I don't like this. You don't belong here. Get out, right? So that's what it does with the sensitivity with the pollen, the weeds, dust mites. It identifies it as if it doesn't belong there. And it says, we got to get rid of this. And so then it builds the immune system or the response in order to go and get it away, right? But it doesn't react the same way as it would a bacteria, a virus, because it doesn't have the ability to remove it, right? To remove the dust, to remove, that's not how it works. Bacteria is different from dust, right? And so because it can't get rid of it, it just keeps coming. It just keeps reacting because that trigger is still there. So the only way to get rid of the signs and symptoms is to get rid of the trigger and to give medication, right? It's not going to resolve on its own through the immune system. If we allow it to continue, it's just going to get worse and worse and worse, right? And the same thing for the intrinsic, in the sense of it's not a sensitivity. It's not that the person is, building an immune response towards it, but the way the body reacts is still in the same way. I don't like this feeling. I don't like this activity. I don't like this medicine, right? So NSAIDs, respiratory tract infections, right? Exercise, inhaled irritants, right? It doesn't like that state. And so whenever the body feels as if I'm under siege or something's happening to me, something's wrong with me, the only thing it can do is say, call out its soldiers to come and help it fight. Its soldiers, white blood cells, right? So the mast cells, they come out to help. So any of these, if we know what they are, if we can help the patient identify it, then we can tell them, listen, dust mites, is that when you start feeling your chest starts getting tight and you start coughing? Oh, it's after you run that you feel this? Okay, so this is what we're gonna do from now on. Either stay out the cold, okay, clean your house, get rid of the dog, do this, right? All of these things we're going to tell them, so we have to know our triggers, okay? So now we're going to talk about what do we do when we realize what the triggers are. We know what the problem is, right? What are we going to do to help? Right, we're going to get rid of them, right? Home improvement. They have a rug that gets dusty too much, get rid of it. They have a plant, get rid of it. They have a cat, sorry. Right? It's like if you don't get rid of it, you have to do something that's going to help you bear the symptoms, right? And it's so funny when I realized that, a person would tell me, oh yeah, I'm allergic to cats. And then they're showing me pictures of cats. I'm like, is that a cat of your sister in another house? They're like, no, that's my kitty cat. And I'm like, but people are attached to their cats and dogs. Like, they're not going to get rid of them. Or, as a matter of fact, some people, they're allergic and they still go buy the cat and bring, it's like, so we have to find ways to tell them, okay, I know you don't want to get rid of the cat, okay, but here's the medication. This is where we start, maybe, we groom them a little more often if it's the hair, right? So, and then there's the lifestyle choices as well. So with the lifestyle choices, anytime there's lifestyle choices, right? We want to decide, okay, what are we referring to? Is it their health? Like if they're, active and their lungs are strong, then it can withstand more issues, more problems, that kind of thing. So we want to make sure that they do stay active. So when, for example, anytime that a person has a problem where the lifestyle needs to change, and it's like you're thinking, okay, well, we got to think about not like certain things we want to remove altogether, right? But certain things you don't want to remove because you know how important it is. So for example, if a person has immune issues, when we saw in leukemia, right? Do we want them not to have any visitors at all? No, right? Because we know people connection is important. So we want to say reduce that. So certain things we're going to reduce. Same thing here, lifestyle choices. A person, gets triggered by exercise. But isn't exercise good for you? Are we going to tell them, no, don't exercise? No, right? So we're going to tell them, prepare. Since you know you're going to need to exercise and you know it's going to trigger it, you know you're going to start hyperventilating or, feel miserable afterwards, take your medicine before. So there's certain lifestyle changes that we can mitigate. We don't have to remove them altogether, but we can try to see, okay, so you're gonna have the cat today, okay, so you're gonna be playing with your cat. Make sure you're in a state where your lungs are able to withstand that, right? Make sure you're continually taking your medication, taking your, the things that helps you with that sensitivity, right? Medication adherence. So the biggest problem that we have, that I have seen, especially with children, especially when I was working in school nursing, is that their parents used to deny that their child had asthma because there's a stigma with asthma. Nobody wants to have any kind of disease as an adult, let alone to think that your child has it and it's like they're scarred for life kind of thing. So I had a lot of problems with adherence to medication because parents or the child was like, I don't have asthma. My mother said I don't have asthma. And I'm like, well, all the signs say you do, so let's talk about this, you know? And so we have to educate people about the stigmas, that it's not a bad thing. There are ways that we can help control it. There are things that we can do. You can have a good quality of life. Because isn't it dangerous if a person has a disease and they don't want to take care of it? Like asthma, airway, breathing, circulation. You need your airway. You don't want to get to that state where it's all plugged up because you're not taking care of it ahead of time. So usually we have this thing, I don't know if you remember, but in elementary school, they do that sprint test to see how fast you can go and how long you can go for. And after that, I will have, like, my office will be filled with kids who didn't pre-medicate because they didn't have asthma, but on record they do, right? And so I would have to have a conversation with parents and explain to them, you know, when you're having this exercise, when you need to do this, please make sure you take your medication. The other thing too, when we think about adherence, is the biggest problem with the asthma is the inflammation. And we have to remember, and when you see this in patho, you'll realize inflammation is good, right? We talked about differentiation is good, but too much of anything good is always bad, right? So if you're constantly having an inflammation reaction, constantly, white blood cells, red blood cells, there's going to be a distortion, right? The cells are supposed to be like this. And then constantly they're opening and closing, opening and closing. What's going to happen to that elasticity? You're going to destroy it at some time. Eventually, it's going to become lax. It's not going to do what it's supposed to do. The cilia are not going to work properly. The cough reflex, all these things are going to stop working because you're overworking them, right? So that inflammation, that's what it's doing, is deteriorating that area. So we want to keep the inflammation at a minimum, right? So and that's with everything, guys. Anytime you think inflammation.
UI server. Low battery.
Oh, sorry about that.
Com.apple.battery-monitor. Low battery.
Okay, so I need. So anytime you want to, you need to mitigate that, right? You want to make sure parents know that corticosteroids that they're using need to be taken morning or night, whatever time, usually in the morning, that they were prescribed, because you don't want that inflammation to happen. You don't want those cells to be destroyed, right? That's the same thing with anything. Inflammation is good, but too much of it is bad. And then we want to monitor the status. We want to see, okay, how well is this medication working, right? They're on the corticosteroids. Is it helping? And the best thing to look at, right, to figure out, is it working, is what is this here? So what does this tell us?
Is that
the peak flow meter. Yes, that's a peak flow meter. What does it tell us? So we talked about it when we first started, right? When we talked about the diagnostics. So when you breathe into it, we see there's a green, there's a yellow, there's a red. Do you remember what it means? When it's red, when it's yellow, when it's green? So when it's green, right, the person blows into it and the level goes to green, that means you're doing fine. You're breathing above the 80%, 85%, the 90% that you need to in order to be in good activity, good energy, good lifestyle. You're doing great, right? So medication, keep it going, you're fine, right? Whatever you're doing, keep doing it. But when you're in the yellow, what does that mean? So the range is lower, right? You're hitting 80, right? And that's not very good for us, right? It's we can't really have good energy if our oxygen is not getting to our lungs or alveoli the way it's supposed to. The exchange is not happening. You're gonna feel kind of a little weak. You're gonna feel unmotivated, like all these things. You might be a little short of breath every once in a while. So that means you need to consider calling your doctor and finding out, how can I change to a better medication, because this one's not working very well for me. And the red, what does the red mean? It's bad. Like within 24 hours, you got to head out to the hospital, because this is not going to be good for you at the end of the day, right? So we definitely need to go seek help immediately, right? And usually if it's done in the hospital or in a clinic, they'll send you to the hospital to make sure that everything is okay, right? Because there's a possibility you might have an exacerbation. What did we say about if a person have an attack? What did we say about that? that we have to keep monitoring them throughout the day, right? It's not just, oh, I took my inhaler and I'm good, but that inflammation takes time to reduce, right? And so we want to constantly monitor it to make sure that it stays, the inflammation stays away, okay? And so when we go back to medication, we mentioned which medication were we going to take. That was the first line of medication we're taking. Albuterol, right? And what did we say that did? Opens it, vasodilates it, pops that thing open right away so that the air can go through. And then we said the other line of medication, what is it called? Corticosteroids. And that one, we said that it keeps what down? The inflammation down, right? So it keeps the inflammation down so that the person can continue to feel good throughout the day, okay? So let's talk about some problems that we're going to see when a person has asthma. So we have the triggers, we talked about them, right? The hypersensitivity with the pollen, with the all these other things, and we talked about okay, if you have upper respiratory infection, that can cause it to exercise. We talked about all of this, right? Familial tendencies, so it runs in the family. It's like a genetic thing, right? And so that's one of the issues there. So hypoxemia, okay? So when a person what are some thoughts that comes to mind when we talk about hypoxemia? So when we say, okay, the signs and symptoms: tachycardia, restlessness, tachypnea, right? So your heart is beating fast. Why is your heart beating fast if you have hypoxemia? So hypoxemia, low oxygen where? Everywhere. Yes, everywhere, but through what? What's emia? The blood, right? So if you have low oxygen in your blood, it's going to cause tachycardia. Why is it doing that?
Get the oxygen.
Yes, right? Because it's like, oh, you don't have oxygen because your heart's not working fast enough, because the heart is what's pumping the blood that carries the oxygen. So if I make the heart work harder, then I'm going to have oxygen. That's what the body feels and thinks, right? And then we have the restlessness. What's the restlessness? Which kind of sign did we say this was? We talked about early or late signs. Which one is this one? It's an early sign. It's an early sign. So when you walk in the room, the person's like, they're anxious, like, I don't know what's, and you're like, what's the matter? Like, they don't even sometimes know what the problem is, right? You have to assess, take their vitals to see, and then you'll notice, oh, your oxygen is low. That's why you're feeling restless, right? Restlessness goes to what? Our minds, right? Our brain. If the brain is not getting enough oxygen, it's not going to be as alert, as calm, as relieved, right? Because it's like, something's wrong with me, but I don't know what it is, right? It's trying to resolve the issue, and then it gets restless. It's a signal for you to think, if you don't give it the oxygen that it needs, eventually what's going to happen? Level of consciousness is they're not gonna be with it, right? They're not gonna be able to know their names, know where they are, right? Remember I mentioned like that some people, they'll come out of their room and they're like, especially older people, they're like they lose it, and you're like, oh, so two things: oxygen issues or UTI is usually when in an old person when they're acting that way, right? So definitely level of consciousness. You need oxygen in your brain in order for you to be alert with it, able to think clearly and know what's happening and how to do things. And then you gotta have tachypnea, breathing fast, right? I need to breathe, I need air, right? The coughing, the mucus, right? Happens because of the mucus increase, shortness of breath, wheezing. What's the wheezing? Why are we wheezing? And what does wheezing sound like? Yeah, that whistling sound, right? Now, question for you. If the person has asthma, you assess them and they're wheezing, and then the wheezing stops. What do we think? What are two things that could happen? Is it good or bad if the wheezing stops? It's bad if you haven't given them any medication. So wheezing is not good. We know that. It tells us there's a problem. But wheezing tells us there's still breathing happening. The airway is still open, right? So now, if it stops, that's an ominous sign. That's like, oh my gosh, there's no passageway now. We need to get help fast, or this person, after 7 minutes or so of not having any air, we got problems, right? So we definitely want to, but if we gave them medication and we know, and the wheezing stops, then we know, but how would we know? Would we just be like, oh, they stopped wheezing, they're good? Is that what we do? What do we do after we've given medication? We assess again. We check the O2. What is the level? What does the lung sound like, right? Like what? And remember, the best way of indicating how well a person is doing is always numbers, right? We want to see lab numbers. We want to see O2 numbers, right? Just by the person saying, nurse, I feel better, right? Or patient looks better, right? That doesn't tell us anything. It's nice. It helps us to say, okay, let's see how better you feel. Let's see if this look equates the numbers, right? We always want to quantify what we're seeing with numbers, right? That's important to us. So we have the CO2 retention. When we talk about CO2 retention, which acidosis level or place are we at here? Where are we here with acidosis? Which kind? Respiratory what? Acidosis, right? Because the carbon dioxide is what? Increased. So it's a respiratory problem, called a problem by its name, and the CO2, which is an acid, has increased. So respiratory acidosis, yeah. And then we have the chest tightness because of that spasm is closing up, and then the retraction. What does a retraction look like? How do we? The word retraction would tell us what? What would we see? Accessory muscles, right? The stomach will be moving, the chest will be moving, the costal area here would be moving. Like the person is very labored, right? As soon as we see that, we're like, oh man, they have issues. We need to get them help like right now, right? So we talked a little bit about diagnostics, okay? So we're gonna do history, okay? Does it run in the family? You know, did they have some kind of respiratory infection, right? Then we're gonna look at the lung function test, right? We already spoke about our, what is it called? Oh my goodness. Peak flow meter, right? But what does the spirometry do? What does that tell us?
It measures the breathing, right?
Right, it measures the breathing, but what does it tell us about the breathing? The
volume.
Yes. The vital capacity, right? How much air can the lung carry, right? When you expel it, it tells us how much was inside. And that's important because our alveoli can take up a lot of air, right? And so if the person is breathing and that little ball is just moving a little bit up, we're like, ooh, it becomes, so what did we say about inflammation? Remember when I said when your fingers are swollen, they become stiff, right? So when the lungs are swollen, they too become stiff. So it's hard for them to expand. And so the spirometer helps it to expand so that it can work and function better after the bout of whatever that caused you not to expand your lungs properly, right? And then we have the nitric oxide, which is another way, a lab they can take to see how the lungs are doing. And then the challenge tests are, you know, like if you're running, right? Or if they give you a chemical that allows your body to have that stress. Well, under stress, right, we have the tachycardia, breathing fast, right? The fight and flight reactions of the body. Well, those things take energy, take oxygen. So how can you accommodate that? Right? How can we, if the person is under stress, can they manage? If they're running, how well does the lung work, right? We want to see that, and that'll tell us how good the lung is functioning. And if it's not doing great, what do we need to do in order to help? X-ray. What would X-rays tell us?
Infection.
Yes, right? It would tell us but what kind of infection? Which one? Bacterial, but would the lung, so will the X-ray say, person has streptococcal? What would it say? Yes, it would tell us they have pneumonia, but what are we looking at?
The density of like bacterial colonies.
Yes. So infiltrates, right? The amount of fluid. The white area tells us it's filled with fluid, right? That shady area would tell us that. So that's what it's telling us. How much fluid? What's the level? Is it all the way up here? Or is it just in the little bottom area? Is it the whole lobe, right? Is it like little, the trachea there, right? When we looked at pneumonia, we saw all the different pictures of x-rays that showed us where the problem is. So this would tell us where the problem is, okay? And then we have the peak flow meter, which we mentioned with the numbers. We said green was what again? Good. You know, your medication is going well. Great job. Keep taking it. What does yellow mean again? Yeah, you should try to call your doctor and see if you could change that medicine because it's not doing very well and you're not feeling very good and your quality of life is reducing a little bit, right? You need to be a little more energetic than this, right? And what does red mean? Go to the hospital because within 24 hours you might have problems, okay? All right, so what are the medications we're going to take? So we're going to take adrenergic, right? We have stimulants. We have SABA. They're albuterol, Preventil versus the salmeterol. So we have the methylxanthines with theophylline. We have anticholinergics with tiotropium bromide. Spiriva, we have the corticosteroids, beclomethasone, which is Flovent, or flucazone, which is Flovent. We have the mast cell stabilizer. So we have a few, right? And so the two most important ones, the two most important distinctions we need to make is what? When we're giving medication, what is the distinction we need to make? Say it again. Yes, the amount of time it takes to take effect. When do we need it to use the one that works fast? Right, when they have an attack. If they have an asthma attack, we're not going to give them a long-acting, which is the corticosteroids. We need a fast-acting because they need help now. And that's something that we have to teach them. If they have both, some people don't have the corticosteroids. They have like rescue medication, which is just the albuterol. So we tell them they only use it when they need it. Right? So you carry it if you have an asthma attack, you use it, you're good. But some people have both because it's that bad. And so you need to teach them the difference. You don't want to take your corticosteroid when you're having an attack because it's not going to help right away, and that's bad, right?
Which one is the fast-acting one for an attack?
So that's the albuterol. The albuterol is the only one that's the fast-acting.
Oh, that just opens.
That opens it. Yeah, that's the bronchodilator that pops it open. Okay? All right, let's answer a question. Okay, so you assist your patient with using the inhaler. The inhaler contains the medication bucenide. Before administering the inhaler, you will want to connect what device to the inhaler to help decrease the patient from developing blank. Which one is this? Yeah, I saw a C, right? Definitely, you want to use a spacer. What does the spacer do? So we said if you're using these medications, right, and they hit your mouth, they cause the thrush, right? So they're hitting the palate, right, and inside the mouth. And so what would we have done? Let's say the person doesn't have a spacer. What would we have done in order to prevent the thrush? Wash your mouth. We would rinse, right, the mouth. But in this case, when they spray it, rather than hitting inside the mouth directly, they have the spacer. It goes into the spacer. It sprays into the spacer. And when they breathe it in, it goes more directly into down the trachea, right? And so it helps prevent thrush much more. Okay, so spacer, thrush. Here's another question. So we're providing discharge teaching to a patient who was admitted with asthma. You discuss the hold on, let me read from here. You discuss the early warning signs of an asthma attack and ask the patient to list some of them. Select all the correct early warning signs verbalized by the patient. So let's see, all that applies. What would the patient say? Remember, early warning signs. Be confident. Yell it out. A, yeah. So easily fatigued with physical activity, right? So that's an early sign. We said the restlessness, like I don't feel right. I don't feel like doing anything. That's restlessness, but also early fatigue. Easily fatigued with physical activity. What's another one? B, yes. So reduced peak flow meter reading. That's another one. What's the next one? Yes, E, wheezing with activity. That's another one. And one more. F, yes, nighttime coughing, right? So those are some early signs. What would be late signs? That means Yeah, retraction would be one, and cyanosis would be one, right? So those are our late signs. No relief when short-acting bronchodilator. That's a very late sign, right? Like that, they've gotten so far, like there's no helping it. It's just too bad, right? We never wanted to get to that level, right? So there we go. About the nighttime coughing, right? That's another thing we think about when we think about like the person when they lie down. Usually, a lot of time, anytime there's a respiratory something, whether asthma, pneumonia, COPD, anything like that, usually in the early mornings they have trouble breathing.